and diagnostic criterion, classification of severity. We look at a bit of epidemiology. Specifically, we look at the 4 diseases. Asthma per se is not very classic as chronic obstructive, but because it's more restrictive, but you're going to do as much as possible. Chronic obstructive airway disease is a chronic state characterized by airflow limitation that is not fully reversible. It's a condition once acquired, it has a permanence, as opposed to asthma, which is reversible, because asthma is dependent on the small bronchioles that have smooth muscle, which constrict. The airflow is limited. The airflow limitation is usually both progressive and associated with an abnormal inflammatory response of the lungs, noxious particles or gases. So this condition, chronic obstructive airway disease per se, is a progressive disease, meaning that the patient will be deteriorating with time. And if you check the pulmonary function, every year you're going to find a pattern of deterioration, particularly if the patient has not changed lifestyle, characteristically exposure to fumes or other particles that are noxious. Prevalence and morbidity data greatly underestimate the total burden of COD. Morbidity increases with age and is greater in men than in women. We spend more time outside, we spend more time mining, we spend more time in the garage and where there's enough smoke and other toxic substances. And currently, globally, is the 4th leading cause of death. These factors are both risk factors are both the environmental and host factors. The first and most important host factor is alpha-1 antitrypsin deficiency. We know this is the one that responsible for inactivating or breaking down enzymes, particular enzymes like elastase. So patients who lack this enzyme tend to have destruction of the lung parenchyma. Patients who have asthma and airway hyperresponsiveness tend to also have COD. Patients also who have disordered lung development, where there is an abnormality in the lung, then can predispose to chronic obstructive airway disease. Environmental factors: number 1, tobacco smoke. Number 2, occupational dust and chemicals. Then we have airway pollution. No, air pollution, either from the airway, the highways, or whichever way. Then I have childhood infections, whooping cough, you know, the famous fall which you do the immunizations against. Then you have lower socioeconomic status, purely because of housing and inability to have filtered environments. They tend to be in the places where the fumes are. They tend to be able to take any job, even when it endangers their lives, whether there is dust, occupational dust or chemical involved. How do we make a diagnosis? COD is considered in patients with cough, which is productive of sputum, with or without, with dyspnea, or dyspnea. So patients need to have a cough, which is productive, and there is associated dyspnea. Plus or minus the presence of risk factors like smoking, environmental or intrinsic. Then you can confirm this by spirometry, where you look at forced expiratory volume vis-a-vis vital capacity.
Can you start?
And you can see the formulas right there.
Yeah, we can start.
So a low peak expiratory flow has
So you
poor
have so many.
specificity for the
Each
diagnosis
of you will
of
only have 10
quad.
minutes.
So
7
you
minutes
calculate
to
the
present,
formulas and
3
you see
minutes for
what is below
question.
70 and what
And
is
moving
below
from one to the
80,
next.
and it's
So
a
we stick
predictive
on 10.
value. The pathophysiology,
So you go ahead then.
usually there is trapping of air within the alveoli. And this increases or raises the reserve volume, and forced respiratory capacity is elevated. There is hyper